Welcome everyone. Thank you for joining this session. I would also like to thank the TxMGMA for the opportunity to speak with you today. This presentation will focus on underutilized virtual services. These services benefit patient care and represent unique opportunities to extend care into the patient's home. They also represent new revenue streams, often for work you are already performing. This presentation will focus on 3 services that hold promise both during and after the pandemic. These services are principal care management, chronic care management, and remote patient monitoring. Telehealth coding and reimbursement was addressed at a different session. We will briefly review the requirements for telephone evaluation and management services, and a select few other virtual services that may add value to your practice. I would like to discuss principal care management services in some detail today. It is likely a service you are not familiar with as it is new for 2020. Given the pandemic, very few practices have attempted to engage this service. At a high level, it is similar to chronic care management services, otherwise referred to as CCM. It's directed towards the comprehensive care of a single high-risk or complex condition. It involves non-face-to-face care, and it is billable monthly. What are the benefits of PCM services? For patients, there's quality of care improvements and reductions in cost. For providers, which means physicians and other qualified healthcare professionals, the same as above, plus compensation for services they're already providing for free. That was kind of the incentive for chronic care management services, and now it's been extended to principal care management services. If you're in a program, a quality-based program such as the MIPS, the cost and quality performance categories may seek significant improvements with the implementation of PCM. All these are yet to be proven because the program is new, but these are the intended goals. For payers and other organizations, this is somewhat new, but they're looking at the cost reductions associated with this and similar programs. We're looking for maybe some benefits to the shared risk programs, the alternative payment models, and other similar organizations and models. Examples would be Medicare Advantage, accountable care organizations, and some of the other APMs which have qualified for the quality payment program. So a lot of information is yet to come in. But when we look at chronic care management, we are seeing some pretty good data supporting the benefits of that program, and of course we're hoping they will extrapolate to PCM. Let's talk about the basic PCM requirements. It's for Medicare patients that are Part B eligible. Practices have to provide 30 minutes of non-face-to-face management services. There are 2 codes, G2064, which is 30 minutes of care provided personally by the provider. Then there's G2065, which is 30 minutes of care provided personally by clinical staff members, which includes providers. Now let's talk about the compensation for PCM services. Code G2064, which is the provider-only code, has an average non-facility compensation of approximately $94 per month. It is up to about $1,100 per year, potentially. G2065, which is the clinical staff member code, has an average non-facility compensation of around $40. That would be roughly $480 a year. A significant number of patients will not require 30 minutes of PCM services each month, of course, and some will require more. What are the conditions that qualify for PCM services? Well, one or more of the following conditions typically expected to last between 3 months and 1 year or until the death of the patient, or conditions that place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. Also, the qualifying conditions may have led to a recent hospitalization. The only source of official information on PCM services is in the 2020 Medicare Physician Fee Schedule Final Rule. In the Final Rule, Medicare listed a number of anticipated circumstances. Care management by a specialist is warranted for the condition. The condition requires the development or revision of a disease-specific care plan. This is actually required for all PCM patients. The condition requires frequent adjustments to the medication regimen. The condition is unusually complex due to comorbidities that are influencing care. The PCM services might be triggered by an exacerbation of the patient's complex chronic condition. It may also be triggered by a recent hospitalization. The primary care practitioner or the patient decide that another clinician should provide relevant care management services for a high-risk or complex condition. It is possible that in the future, informed patients will seek out specialists that offer PCM services. The goal of the treating specialist when providing PCM services is to, as per CMS, eventually return the patient to the care of the primary care practitioner once the condition has become more manageable. This makes it sound like PCM services are reserved for specialists only. However, CMS clearly mentioned that primary care providers can also provide PCM services. The goal of a primary care provider would be to manage a condition that would benefit from these additional services. I wanted to provide you with the definitions for the PCM services straight from the horse's mouth, so to speak. In this case, the horse happens to be CMS. Some of this may be repetitive, but I wanted you to see the exact words used by CMS to describe these services. Let's review the provider-only code G2064 first. This includes comprehensive care management services for a single high-risk or complex condition. A physician or other qualified healthcare professional needs to spend at least 30 minutes personally providing PCM services during the calendar month. The definition reads that one or more of the following elements must also be present. As you can see, we have covered these elements previously, but just to review, one complex chronic condition lasting at least 3 months needs to be present, and it needs to be the focus of the care plan. If the condition was of sufficient severity to place the patient at risk for hospitalization, or was the cause of a recent hospitalization, that would be a factor that would qualify it for PCM services. Another element is clearly non-optional, and that is the development and/or revision of a disease-specific care plan. Patients with high risk or complex conditions that require frequent medication adjustments would also qualify. No examples were provided, but CMS did state that if the patient had comorbidities that were complicating the condition being managed, that would qualify as well for PCM services. It is not clear at this time if two providers both contributed minutes and the sum total added up to 30 minutes, if that would qualify for this service. At this time, it would appear that that is not acceptable and that the billing provider needs to personally provide the PCM services. For completeness, we'll show the definition for the PCM service code G2065. This is the code that is submitted when clinical staff provide the 30 minutes of service time. The requirements are otherwise identical, and it is very clear that more than one staff member can contribute, and then the total number of minutes is summated to determine whether or not the 30-minute threshold has been attained. Now let's take a deeper dive into the PCM requirements, getting into the weeds, so to speak. Next, let's talk about the supervision requirements for clinical staff members. PCM services may be provided incident to the physician's license under general supervision. This allows PCM services to be provided remotely by clinical staff members, such as from a call center. Determining who is and is not a clinical staff member in your practice can be a little tricky. Definitions vary from state to state. For example, many medical assistants qualify as a clinical staff member in one state but do not qualify in another. In Texas, medical assistants generally qualify as clinical staff members, although it is up to the physician to determine if they have the adequate knowledge and skills to perform the services. What activities would be considered eligible for PCM service minutes? Well, telephone calls, the portion spent on the care, of course. If you have a long conversation with a patient and only part of it's related to healthcare, that would not qualify. Correspondence between the clinical staff member or physician and the patient, such as secure email communications, portal communications, and communications through a healthcare application. If you discuss the care of the patient with another staff member, that time can count, although only one person can count that time, of course. Managing an organization and organizing patient information, lab study results, etc. counts as well. Care plan updates and communications with other care and other service providers. That includes speaking with a primary care specialist, other specialists, the emergency department, the hospital, community health centers or services, skilled nursing facilities, assisted living, etc. Consent must be obtained. It can be either verbal or in writing, and it can be done over the telephone. It must be documented in the medical record, however. Consent only needs to be obtained once, and the patient needs to be informed that PCM services are available. Only one provider can bill per month for PCM services. PCM services can be stopped effective at the end of the service period. So if they stop it early in the month, they're still obligated to pay for the services, their portion of the payment through the end of the month. And the cost sharing does apply. It's still the 20% Medicare copayment, which can be problematic. Of course, most patients have supplemental insurance that will generally cover the copayment. If the patient has not been seen within the past year during a face-to-face or telehealth visit, there needs to be an initiating visit for PCM services. The visit must be an E&M service, office service, such as a traditional office service code 99202 to 99215, an annual wellness visit, or an initial preventative physical examination, the IPPE, and they're all separately payable, of course. Time spent providing non-face-to-face care on the same day as an E&M service cannot be counted towards PCM service time. This can be really challenging to track and hard to remember that it's even a requirement. So that's something to be on top of. Make sure that if the minutes are recorded and the dates match an E&M service, they are not counted towards PCM services. Practices must be, quote, using a certified EHR. The EHR needs to be certified to the 2015 edition requirements. For each PCM patient, core patient information needs to be recorded in the EHR. So demographics, problem lists, medications, and allergies. And those are all problems, all medications, of course, etc. There's no current requirements tied to the Promoting Interoperability Performance Program that looks at EHR usage. That may change in the future, but at this time, the fact that you are using a certified EHR meets the requirement. The practice must provide 24/7 access to a practitioner, a licensed professional such as a physician or a mid-level provider. Patients and caregivers need to be able to reach out. They can reach out through the call center, but the call center has to have the ability of reaching the physician 24/7. Crossover arrangements are allowed, so if you're a small practice and you get coverage from another practice, that's acceptable. However, there should be a contractual agreement between the practices. The practice must also designate a care team member to be assigned to the patient and must offer enhanced communications. The designated care team member is an individual who should be identified at the onset of PCM services as the point of contact. This is not limited to providers, however. The patient should be informed when the designated care team member is changed. Enhanced communication opportunities refer to the practice offering asynchronous non-face-to-face methods other than telephone to communicate. Examples of this would be secure email, portal communications, or communications through a healthcare application. Let's talk a little bit more about disease-specific care management. It should include a systemic needs assessment that includes medical and psychosocial issues. However, this is only applicable to the specific conditions that it is being managed. The practice needs to ensure receipt of preventative services. Again, only as applicable to the condition. So if a patient has COPD, it would be important that they get their immunizations for the flu, but it may not be as essential if they had Crohn's disease. In that situation, a GI specialist may defer to the primary care specialist to manage the preventative services for the patient. Care management should include medication reconciliation, management and oversight of self-management of medications, if medication management is applicable to the condition. This would also be limited to the specific medications for the condition. CMS is emphasizing ongoing communication and care coordination between all practitioners caring for the patient. In addition, these interactions must be documented in the patient's record. An example of this might be when a neurologist is managing a patient for multiple sclerosis and the patient is discharged from the hospital after receiving care for heart failure. In this situation, the neurologist would not be obligated to manage the communication and care coordination associated with the patient's transition from the hospital to home. Another requirement is an electronic care plan. This can be created in an application or within the EHR or whatever mechanism works best. It can even be created using Microsoft Word or Excel, etc. Just has to be in electronic format. It needs to be revised or monitored as needed, and the plan needs to be available in a timely manner as needed. Timely is referred to usually within business days, 1 or 2 business days. It can be sent via any electronic method, including fax. A copy of the care plan needs to be given to the patient or caregiver, and it can be made available to them. Again, the format is not specified as to what needs to be given to the patient, so it may include paper versions of the care plan. You can make it available on the patient portal or distribute it through other means. Maintaining a care plan can be somewhat labor intensive for some patients. Fortunately, the time spent updating the care plan counts towards the PCM service time. There's some degree of flexibility with what needs to be in the care plan. CMS provides a list of typical requirements for the care plan. For all patients, it should include demographics, problem list, medications, medication allergies, and the condition being managed, of course. The things that you have to maintain are only applicable to the condition being managed, such as expected outcome and prognosis, measurable treatment goals, symptom management, planned interventions, and identification of the individuals responsible for each intervention. As you can imagine, these requirements under chronic care management are much more challenging. Medication management, if relevant, and then of course community and social services ordered would be included if they are relevant, and a description of how services or agencies and specialists outside the practice are directed and coordinated by the practice. The care plan should be scheduled for periodic review and then revised as necessary. Medicare emphasizes the importance of the management of care transitions and referrals for both PCM and CCM, chronic care management. However, for PCM, only transitions and referrals applicable to the condition being managed need to be managed. Examples include when the condition is affected by discharges, emergency department visits, a follow-up with another specialist or primary care provider, referrals that have been sent out regarding the condition or related to the condition. Applicable transitions and referrals should be supported by the creation and exchange of a summary of care document. This is the document that is required for the Quality Payment Program, in particular the MIPS Promoting Interoperability Program. However, unlike the Promoting Interoperability Program, the exchange method is not prescribed, so it can be sent via paper. Electronic methods, including fax, are acceptable. While this is more applicable to primary care providers, transitional care management services can be billed in the same month as PCM services. If it is applicable to the condition being managed, the practice should oversee home and community-based care coordination. This should include communication and discussion of psychosocial needs and functional deficits, and this needs to be documented in the record as per CMS. Is the practice required to meet each requirement each month? As per CMS, quote, all elements that are medically necessary and reasonable must be furnished during the month, but all elements do not necessarily apply every month. In other words, use your best judgment and hope that the auditor agrees with you. Next, let's review a few PCM clinical examples. One example might be Crohn's disease managed by a GI specialist. The specialist identifies the need for PCM services as the patient is requiring a great deal of supportive care outside of her office visits. The designated team member is assigned who speaks with the patient and consent is obtained. The clinical staff then creates a care plan that is reviewed and approved by the billing provider. Clinical staff provides ongoing weekly communications with the patient regarding the status of their condition. They evaluate the patient for symptoms, their weight, medication use, dietary counseling, follow-up visits with nutritional professionals, and they connect the patient to a support group for Crohn's disease. The physician is communicated with as needed during the process. The staff members, including the providers, have a total number of minutes added up to plus 30. It's all documented and tracked. Once the 30-minute threshold is obtained, they can submit code G2065, which reimburses approximately $40. Much of this likely represents activities the practice is already performing, but for which they are not being reimbursed. Another example would be a patient with heart failure managed by a cardiologist. A male patient was recently discharged from the hospital. He remains symptomatic with shortness of breath at home. He lives alone. and the cardiologist has been having weekly communications with the patient and his caregivers to fine-tune the patient's care. The provider spends an average of 8 minutes per week personally providing the care management services. Under those circumstances, the provider would then bill G2064, which pays at a significantly higher rate at around $85 to $95 per month. A third example would be a patient with multiple sclerosis who is managed by a neurologist. The patient had a recent exacerbation of her MS and is required to stay at a rehabilitation facility. The patient is transitioning to home. Significant activity around connecting the patient to home services, physical therapy, and meal services is required to help manage the patient, and the patient has a comorbid condition related to the multiple sclerosis, that being a pressure ulcer. 30 minutes of clinical staff time spent providing management services, coordinating care for her comorbid condition, and providing her with psychosocial assessment and help, etc., is provided, and this easily tallies 30 minutes per month, and the practice can submit code G2065. As I mentioned earlier, chronic care management gave rise to principal care management. They are very closely related, but they have some unique differences I thought it would be good to highlight. For those of you who may not be familiar with chronic care management services, I'll provide a brief overview. It's a Medicare program that has been active for 5 years. It reimburses practices for care provided to patients with 2 or more chronic conditions. They have to have a duration of at least 12 months, which we will talk about later. They require the practice to manage all aspects of patient care, and that is very challenging for specialists. A comprehensive care plan is required that addresses essentially all aspects of patient care and has to be maintained. There are multiple reimbursement pathways, however, for chronic care management, so financially it may be a better option if you have the ability to offer both PCM and CCM services. Since chronic care management services have been out for a little while, we have some data to look at to see what benefits they may provide. A study commissioned by CMS evaluated the CCM program after its first 18 months. They found that enrolled patients were hospitalized at a lower rate than non-CCM patients. The CCM patients utilized the emergency department less than the control group. The average reduction in cost of care if you were in the CCM program versus not was $95 per month. The CCM patients had significantly higher rates of advanced care planning. They ended up having actually more visits with their primary care physician. This actually kind of makes sense because they're in constant communication with the practice, and when situations arise, provider may recommend the patient come in and be seen. And this could help to prevent some conditions that could lead to complications, so that is seen as a favorable thing. And they utilized more home health care services, which is also seen as potentially beneficial to the patient. Now let's compare CCM to PCM as far as available codes for reimbursement. CCM has multiple codes. There's non-complex CCM services with the codes listed below, 3 separate codes, complex CCM services with 2 codes, and there's even a code for when you do an extensive assessment when you're onboarding the patient during the initiating visit. PCM has only 2 codes at this time, the G2064 and 65 that we've been discussing. This table serves as a CCM services reimbursement matrix. These are the average non-facility payments. So the original code, 99490, non-complex CCM services, 20 to 30 minutes by clinical staff, reimburses about $42. The code G2058 is an add-on code for 99490. This is used when you exceed 40 minutes. It may be used a maximum of twice per month. As you can see in the third row, if 99490 and G2058 are reported together, it generates about $80 in revenue. If G2058 is used twice, it goes up to $118 in revenue. So for patients with significant needs for CCM services, the reimbursement rates are fairly high. 99491 is a physician-only code, and that has to be for activities personally performed by the physician. And in that situation, the practice can bill 99491. Reimbursement for this code is around $85 to $95. The next code in this list is 99487. This is for complex CCM services of 60 to 89 minutes. Complex CCM services differ from non-complex CCM services primarily by the fact that the complex CCM services require moderate to high levels of medical decision making. This service reimburses at approximately $95. The next code, 99489, is an add-on code for the complex CCM services of 60 to 89 minutes. If both are submitted together, meaning that between 90 and 119 minutes of complex CCM services have been provided, the reimbursement would be $141 approximately. The last code in this table, G0506, is used once per patient during the initiating visit if the provider provides extensive assessment and care planning that is outside of the normal scope of the E&M service for that type of visit. The PCM services reimbursement matrix is much less complicated. The average non-facility payments are shown. And as we've discussed before, the provider-only code reimburses well up to $95, and the staff code G2065 reimburses around $40. CCM services started with just one code in 2015, 99490, and has been expanded significantly since then. As you can see, we imagine PCM services will be updated over time. I thought it might be timely to emphasize the PCM and CCM provider-only services. They are significantly underutilized, but given the current circumstances, they may play a valuable role. It might be worth evaluating these services closely and looking what kind of bandwidth you have for providers in your practice. Some practices may find that having their mid-level providers provide this service might generate new revenue and allow them to extend care into the patient's home. Each one of these, though, requires a minimum of 30 minutes of provider time. That's quite a bit of time. In most settings, if you're very busy, it's probably not applicable. However, in some settings around the country, they have been reducing the staff and furloughing nurse practitioners and physician assistants because they didn't have enough work. It potentially might have saved their positions if they were put to work providing PCM services or CCM services as applicable. A good fit might be when you have selected patients with significant management challenges where you'd like a provider to reach out to them on a weekly basis or more frequently. Situations where, of course, providers have additional bandwidth, and situations where providers are quarantined at home might be suitable for these services. I would also like to do a side-by-side comparison of the qualifying condition requirements for CCM versus PCM. CCM services, as we mentioned, require 2 or more chronic conditions. These conditions are expected to last at least 12 months or until the death of the patient. Like PCM, the chronic conditions place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. PCM, though, allows for conditions expected to last for as little as 3 months or until death. Conditions don't have to be technically chronic in nature like they are for CCM services. CMS did not provide examples of applicable conditions, but one can see where, say, a patient with a neoplastic process where the oncologist feels they could recover within several months might be suitable for this service. The same patient may not be eligible for CCM services. The biggest challenge for providing CCM services if you're a specialist is that total care has to be provided. It requires comprehensive management of all aspects of the patient's care. This may be challenging for some specialty practices that are focused on certain disease conditions. An exception may occur, though, when a specialist is providing primary care. This might be in a rural community or another setting, or if the specialist feels comfortable providing the primary care services. PCM really allows you to focus on one condition at a time, which is very helpful from a specialty viewpoint. Another challenge for specialty practices would be the creation and maintenance of a comprehensive care plan. It needs to be based on an assessment of the patient's physical, mental, cognitive, psychosocial, functional, and environmental status and needs. It is not required for PCM, or these components are not required for PCM unless it is applicable to the PCM condition that is being managed. The CCM plan also refers to an inventory of resources available to the patient that need to be documented in the care plan. In PCM, of course, this is limited to the resources that are applicable to the condition that is being managed. Another consideration is the management of care transitions. Under CCM, the billing provider must manage all transitions of care and referrals. That includes hospital admissions and discharges to rehab hospitals and SNFs, emergency department visits, specialist evaluations, etc. All that has to be stayed on top of and documented in the care plan, which can be somewhat labor intensive. PCM, again, is just limited to the management of transitions of care that are relevant to the disease being managed. A significant advantage of chronic care management versus principal care management are the clinical staff time requirements. Both services offer reimbursement for supervised clinical staff time. However, the threshold for CCM, code 99490, only requires 20 minutes or more of CCM services, and there are add-on codes for additional increments of 20 minutes. The complex services require 60 minutes, and they have an add-on code. PCM requires 30 minutes of clinical staff time. It is unclear as to why 30 minutes was chosen, although it is hoped that this number will be reduced in the future. At this time, though, it does require 30 minutes of staff time, which may be a relatively high bar for some practices. Both services offer the same time requirements for the services provided personally by the billing practitioner of 30 minutes. This is a relatively high bar, but it may be applicable in certain situations, as we've discussed. Again, these services may be worth consideration for your practice. Most physicians have several patients in their practice that would benefit from these services, i.e., frequent direct communication with a provider. Next, let's talk about PCM compatibility with other services. The following are services that can be provided concurrently with PCM and CCM. That includes transitional care management, or TCM services, remote patient monitoring codes, certain ones, 99453 and the others shown on the screen. We'll be talking about RPM as well in this discussion. Inherent E&M complexity codes, these are add-on codes for visits that are inherently complex, GPC1X, which is new for 2020, and then CCM if it's billed by a different clinician. So you could have two providers in the same practice, and one is providing CCM for a patient and the other is providing PCM services for the same patient. They can both bill. Services that cannot be provided concurrently with PCM and CCM include the one remote patient monitoring code called 99061, behavioral health integration services. CCM, as we mentioned, if billed by the same clinician, cannot be reported, but it can be if another provider in the practice submits CCM concurrently. It cannot be used for the surgical global period, and it cannot be used concurrently with the interprofessional consultation services with the codes listed on the screen. And the time spent monitoring E&M services during the same calendar day cannot be counted. That's particularly challenging, as I mentioned earlier, is you had a PCM or CCM service on the same day that you saw the patient for an E&M visit, including a telehealth visit. The staff would, of course, continue to diligently report their CCM or PCM minutes on the same day. This is a common error and will likely be the focus of future audits. However, it can be addressed as part of the quality assurance process prior to claim submission. There are a number of challenges related to implementing PCM and CCM services. This is the feedback we've had primarily from the CCM implementations. The 20% copayment has been a burden to some patients. However, it's not applicable to most patients, so you have to clearly explain to the patient that their supplemental insurance, if they have it, should cover the copayment. There is a proposed bill that it's unclear where it stands right now, where there was a movement to eliminate the copayment. but that's not in the works at this time, to my knowledge. You also have to be worried about staff availability to provide management services. Some practices have tried to implement this on a large scale and have not addressed the staffing needs. There's an internal model that might be best to start with a slow ramp up of staff or with staff supplementation. There's also an external model where you engage with a call center. Another challenge is how do you track time spent managing patients for CCM and PCM services if you have multiple providers, multiple staff members, all contributing minutes and documenting. This has been challenging for EHRs to handle, in particular the time tracking element of CCM and PCM and RPM services. There are various software packets available that communicate with your EHR and are specialized for these services. I've evaluated a number of them mostly from a compliance standpoint, and I can say they're getting better. It was a bit of a rough industry initially, but things are really turning around now, so that's something else to consider. Another challenge may be patient acceptance. Some patients don't feel they need the service. It makes sense to offer these services to patients who would benefit from it the most. Some approaches have been to sign up all patients who meet the criteria, but the dropout rate from the program is relatively high if that path is taken. Let's briefly review PCM and CCM implementation considerations. A good first step might be to assess your patient population and determine the number of eligible patients for PCM and CCM services. This should be targeted towards patients who would benefit from the services, not the relatively healthy patients who may have one condition or two chronic conditions, but are doing fairly well on their own. Determine the return on investment. Look at the staffing needs and time and consider outsourcing to a care center model. Care center models allow you to get up and running very quickly, but there is a cost-sharing aspect. Become familiar with the requirements. We anticipate that there will be significant audits occurring for CCM and PCM services. The OIG did an audit last year, and they mostly looked just at codes. They did an audit of CCM services. They did not go into the details where there's so many apparent audit vulnerabilities, like whether or not you documented the care provided during the CCM service time, how the minutes were tracked, etc. That they haven't done yet. It's a really good idea to determine your software needs. How well does your current EHR support these services? If your EHR does not have the ability to track time or has other limitations such as dashboards, etc., or support for when to send the billing codes based on meeting the time requirement, etc., then you may want to consider an add-on application from a separate vendor, or maybe go through your EHR's marketplace to identify the particular vendor for RPM, CCM, or PCM services. You should also review your reimbursement workflows. Is the billing team aware of the requirement that CCM, PCM, or RPM minutes cannot be billed on the dates of an E&M service, an office visits, for example? Of course, your staff will need to be educated, and you'll also have to determine who does what in the process and what additional resources you may need. And then you'll need to monitor for usage and compliance. These services seem to have a number of hidden compliance issues that may be difficult for practices to sort out. I like to use the example of an audit comes 5 years from now, and they ask for a specific month and documentation to support the services provided. That can be very challenging. However, these services do seem to have a realistic benefit to patients in areas of quality improvement and cost reduction. Next, I would like to discuss the digital office, i.e. the office of the future. The way things are trending right now with the explosion of telehealth, folks are more comfortable with electronic means of communication for healthcare, and other services besides telehealth are blossoming right now, including CCM, RPM, and potentially PCM. Essentially, every practice that sees Medicare patients may wish to consider some of these services. They are also being offered through commercial services, although not quite at the level that they are for Medicare patients. The services practices should think about are CCM and PCM, RPM, telehealth services in the post-pandemic era. Telephone services may still be available, although we think the reimbursement will be reduced. E-visits and e-check-in visits are also available at this time. Let's take a fairly close look at remote physiologic monitoring, often referred to as remote patient monitoring or RPM. The RPM services shown in this slide are the ones being used most prominently right now. There's two setup codes that cover the initial setup of the patient education, and then the other recordings, the data side of that for 30 days. And then there's the ones that require the clinical component. The other two codes, 99457 and 458, are for monitoring of the data coming in for a total of 20 minutes during the month, with other requirements that we'll review quickly. Other RPM codes to be aware of, they're not used quite as frequently, include 99091, which is 30 minutes of provider time. And then there's two codes for self-measured blood pressure. Like PCM and CCM, these services require patient consent. Let's go into a little more detail about the RPM setup and data collection services. There are two codes, 99453, remote monitoring of physiologic parameters, device setup, and patient education. This one can only be submitted once per episode of care, and the service ends with the attainment of the targeted treatment goals. 99454 is the monthly supply of device and components for remote monitoring, and that also includes the cost of the device. Additional requirements for these setup services include the fact that the device must be a medical device as defined by the FDA. There are devices such as off-the-shelf blood pressure cuffs and glucometers that meet this definition. The physiologic parameters measured are not restricted. It can be weight, blood pressure, pulse oximetry, glucose levels, and other types of parameters. However, they have to be captured as digital data. The device needs to automatically send physiologic data on at least 16 calendar days in a month, and it's actually a 30-day period. The services may be provided by auxiliary staff members. So, for example, technicians can be hired to even go to the patient's home and to set up the devices for their use. These technicians do not need to meet the definition of clinical staff members. Okay, you're collecting the data. Now what do you do with it? There are two codes that address the effort related to treatment management services. So the data is being collected and reviewed, and the personal communications. And at this point, it looks like it needs to be an audio communication via the phone, a synchronous audio communication. If that is up to 20 minutes, there's a reimbursement code for that, and that's 99457. If an additional 20 minutes occurs, then 99458 can also be reported. The management services may be provided by clinical staff members, incident to general supervision by the provider, and that's something new for 2020. Before it had to be the provider. It must include a live interactive communication with a minimum of two-way audio, as I mentioned. This is in the proposed rule for 2021. A number of individuals providing this service feel that time spent providing care for the patient should count, not just direct communications via telephone. However, at this point, that is what's proposed in the final rule for 2021, and we'll have to see what happens in early November when the final rule is released. At this point, it would be preferable, in my opinion, if the service time spending reviewing the data, speaking with the clinicians, documenting the treatment plan, etc., all counted towards the 20 minutes. However, this is not my call. It is clear that time spent providing this service on the same day as an E&M encounter should only count towards the E&M encounter. It's also worth mentioning the other RPM code that targets physician reimbursement, and that's interpretation of physiologic data, 99091. The description for this code is the collection and interpretation of physiologic data digitally stored and or transmitted by the patient to the provider, and it's a minimum of 30 minutes of time each 30 days. Data management services must be performed by the provider personally. The patient must have had a face-to-face encounter with the billing provider within the past year, and the time spent involved with data accession, review and interpretation, modification of the care plan, etc., all counts towards the time, as opposed to the other RPM services I mentioned in the last slide. There is no requirement for a direct interactive communication with the patient or caregiver. However, the 30-minute requirement has been a bit daunting for a number of practices. Of interest for this service, there is no specific medical device requirement, so a home-built app or something of that nature that does not meet the FDA definition of a medical device could potentially be used for this service. This is unclear. Concurrent billing, it may be billed concurrently with CCM and TCM. It may not be billed concurrently with remote physiologic monitoring service codes 99457. That would be redundant. As per the CPT professional book, it states that it may not be billed concurrently with CCM service codes, but that seems to be in conflict with CMS advice. The time spent providing the service on the same day as E&M encounter, again, counts only towards the E&M encounter. This slide reviews the reimbursement for the RPM services. As you can see, the first two codes, 99453 and 54, address the setup of the device, and you'll see the first code is just $22. The second code is $65, but includes the cost of the device. The next two codes are the ones that work together with the first two codes, and that's really just reviewing the data generated and managing it. So the first 20 minutes is worth $54, and if you have an add-on code, additional 20 minutes, it reimburses $22, which isn't as much as you might think. If the services are performed together, all four codes, assuming you have 40 minutes of service time, it can be up to $163. The other code I mentioned, the one that's 30 minutes of provider time, 99091, has a reimbursement of $72. Next, let's talk about some additional virtual services that will be available during and after the public health emergency, when we can all take off our masks. Now let's talk about telehealth in the post-pandemic period. Individuals experienced with providing telehealth services during the pandemic have identified several use cases where they feel it has value. These include mental health conditions, skin ulcers, post-operative care, congestive heart failure management, and other conditions. Telehealth has clear value for other situations such as inclement weather, long-distance travel, patients that have difficulty with transportation, patients with childcare needs, and patients that cannot afford to take time from work. Younger patients are already seeking out practices that provide telehealth as a service. Telehealth also allows practices to extend their geographic footprint. Unfortunately, this also allows remote practices to encroach on your space. Now let's briefly talk about telephone evaluation and management services. These services have demonstrated value during the pandemic. They may be discontinued after the public health emergency. It is more likely they will remain, however, their payment amounts may be reduced. Although the OIG has stated they will exercise enforcement discretion for telehealth services, it is important to remember their compliance requirements. The rationale for not providing a telehealth visit, i.e. with video, must be documented. As per CT, this service should be initiated by the patient. However, the exact meaning of that is not clearly defined. The service cannot be related to an E&M service provided within the previous 7 days, and it cannot lead to an E&M service or procedure within the next 24 hours or soonest available appointment. The amount of time spent on the phone with the patient and the nature of the conversation and care must be well documented. As you can see from the table, the minimal amount of time you can spend is 5 minutes. However, telephone conversations of 21 minutes or more pay at a rate that is equivalent to a 99214 office visit. Again, remember to document that the patient does not have access to video technology. As per CPT guidance, established patients only are eligible for this service. However, during the pandemic, it may be provided to new or established patients. Please also note that the payment rates being equivalent to office visits for established patients is limited to the pandemic. Clinicians that are not eligible to provide E&M services may also report audio-only services. This includes physical therapists, occupational therapists, speech-language pathologists, social workers, and dietitians. They would use the non-physician codes 98966 through 98968. E-visits represent another underutilized virtual service. They may be reported when a patient initiates a service inquiry and the provider spends 5 or more minutes of cumulative time in a 7-day period providing remote evaluation and management services. As per CPT, this service may only be provided to established patients. However, during the pandemic, it may be utilized for new patients as well. The time requirements for each corresponding code are shown on the slide. What may be challenging to remember is that the initiating communication from the patient must occur via a HIPAA-compliant secure platform. This would include patient portals, an email, or other digital application. In other words, it cannot be initiated by a phone call. However, once it is initiated, all communications, including phone calls, count towards the time. Similar to telehealth and telephone E&M services, the OIG has said it will exercise enforcement discretion regarding co-payments for this service. This is limited to the pandemic period, of course. Another challenge with this code is that if the patient receives an E&M service within 7 days of the initiating communication, any of the code may not be reported. It is also not reported if the patient-initiated inquiry stems from an E&M service provided in the past 7 days and is for the same problem. If an overlapping E&M service occurs during the 7-day window following the initiation of this service, the time and/or complexity involved with providing the e-visit service can be used towards determining the level of service of the E&M office visit. It is important to document the amount of time spent during each patient interaction and what was discussed. As noted previously, there are a wide range of activities that count towards the time for this service. Clinicians that do not have evaluation and management services in their scope of practice may provide these services using the codes listed below. These codes are applicable to physical therapists, occupational therapists, speech-language pathologists, and clinical psychologists, and other clinician types. Now let's briefly discuss virtual check-in services, codes G2010 and G2012. Code G2010 represents the store and forward service. It may be reported when patients send recorded images or video for evaluation. The clinician needs to provide interpretation and follow up with the patient within 24 hours. The other virtual check-in service, represented by code G2012, is a brief virtual, for example, telephone communication with a patient. The communication must have a duration of at least 5 minutes. The time spent and the issue discussed with the patient must be documented. For both of these services, it is for established patients only. However, during the pandemic, it may be provided to new patients as well. It is limited to providers, and it cannot be billed if the service originated from an E&M service within the past 7 days. If the service leads to an E&M service or procedure within 24 hours of the telephone call or other communication, the service cannot be billed. The service must be initiated by the patient. It might be timely to consider virtual services from the perspective of the patient. For example, remote patient monitoring services are becoming popular with both clinicians and patients. Clinicians are recognizing the value of having multiple data points received on a daily basis that allow you to monitor patients when they're not in the office. Several studies have reported cost of care reductions associated with RPM and related home monitoring services. Shared risk programs such as Medicare Advantage organizations are launching pilot studies to evaluate the effectiveness of RPM in reducing cost. Another consideration is how these virtual services will affect patient retention and also provider retention and recruitment. Patients and their caregivers will begin to expect offices to have more of a digital footprint. Patients now have the option of being seen by providers who are hundreds of miles away, if not thousands of miles away, through telehealth. It may be more challenging to retain patients given all the options they have now. It may also be possible now to expand the geographic range of your practice. Having a digitally enabled practice may also help with recruitment of healthcare professionals, in particular those who are emerging from training. This concludes the presentation. Thank you for your time today. My contact information is listed below. Please reach out to me for any additional questions. We have time to take some questions from the audience now.